Let's get started, yeah? So welcome everybody to the APAC community call for April. Today we have some APAC news to share. We also have loads of global news to share, and then we'll move on to have one of our Korean collaborators introduce his participation and his leadership in one of the OHDSI Global's guideline-driven evidence generation initiative. So without further ado, going to the first APAC news. So I know we've had this initiative a long time ago where we had each of the country regional chapters do their own translation of the Book of Odyssey. We also have a ongoing update of the Book of Odyssey right now from the global end as well as one of the initiatives for this year. However, I do want to highlight the fact that our Japan collaborators have successfully translated the Japanese version of the Book of Odyssey. So this is a good effort in disseminating the Book of Odyssey in Japan, as well as Odyssey and OMAP in Japan as well. However, good news and bad news for the Japan colleagues is they'll need to update when the Book of Odyssey is updated. But again, we have a lot of tools available right now in terms of AI and what we can leverage. So hopefully the effort will be less. But yeah, this is great news from our colleagues from Japan. Excellent. Moving on to the next news. The first edition of the APAC newsletter for 2025 has been released. Of note, this was entirely prepared by another one of our Japan collaborators. So Keiko has generously offered up to take ownership of the newsletters for this year and hopefully moving forward. So she's prepared this. It has been sent out, if I recall correctly, 1 or 2 weeks ago. The QR to the newsletter, in case you haven't received it in your inbox, is here for you to go into. There's also a subscribe button in that specific interface in case you are not subscribing. Again, if you're part of the OHDSI APAC teams, you will be getting these newsletters. If you haven't got it, it means it's either in your spam or your email is not registered as part of the OHDSI APAC teams yet. So if you are joining these meetings by somebody just forwarding you the invite, but you want to be more involved in the community, please do sign up and we can get you onboarded into the APAC team so that you receive these reminders and newsletters from the community. Thank you, Keiko. I don't think she's here in the call with us, but hopefully she'll see herself in the recording if she has time to watch it. Moving forward, with regards to the OHDSI China studies that were proposed last month. So thank you all to the OHDSI China collaborators who presented their study proposals. I saw it was a great session. And also everybody who was in there from the global side and the mentors from the OHDSI Global folks that provided great feedback throughout the session, right? Following the presentations, we had a poll to vote for which study we think are the best studies for us as a community to move forward with. The 3 studies here have been selected as the top 3 studies. So in terms of next steps, we'll be kicking off an introductory call where we'll be finding out more about where each of these studies are at and how we as a community can guide these studies moving forward. And hopefully we can have some initial preliminary results to be shared at the APAC Symposium coming up in Shanghai in December this year. So please stay tuned for any news around that. And then we'll move on to global news, right? So for those of you who are paying attention to the calls happening from the global side, the latest update for our OHDSI vocabularies is now available. It incorporates new drugs, procedures, and lab tests, as well as improved mappings for conditions, and also expanded hierarchies within the vocabulary. So for those of you who don't know, the vocabularies are not static. They are continuously updated and maintained by the OHDSI community. It is a community contribution, and if you think you're done by just doing a one-off conversion of your OMAP database instance, you're wrong. You need to update your vocabulary tables on a regular basis. You also need to update any new data coming into your database into your source database as well. So please, if you have an OMAP instance, please update your vocabularies. There's a lot of benefits from updating. You can read the full release notes at this URL. The deck will be available on odyssey.org for you to refer to if you haven't found the URL already yourself. Next news. So DevCon, for those of you who don't know, DevCon is an annual event happening in Odyssey Global. It gathers all the developers and engineers within the community, and we have sessions discussing about how we as a community can better do open source development, right? So it's happening April 25th, 9 a.m. to 2 p.m. Eastern time. I know this is not great time for us in the APAC time zone, but good news, you can do it overnighter and you can tell your boss, I'm not coming to school or I'm not coming to the office the next day because I attended the DevCon, right? So do it all-nighter if you guys are interested and you guys are developers and engineers contributing to the community. It's a from what I hear, it's a very interesting session every single year. So that's on the DevCon. Next news. So we are all looking forward to the Global Symposium, right? So dates have been fixed, October 7th to 9th. We also know where it's happening at. So New Jersey, Hyatt Regency Hotel. News here is that the collaborator showcase submissions will be due by July 1st. So their submissions are not open. Thank you, Jiwon. I thought I made a mistake on the timings, but thank you for the conversion to the time zone, APAC time zone. Excellent. In terms of the collaborator showcase for the Global Symposium, there is a due date announced. The submissions have not been released yet. So put a block in your calendar to make sure that you submit in case you are interested to submit any work that you've done this year to the APAC, to the Global Symposium. Agenda and registrations will follow as they come up from the global side, right? So keep an eye out for that. Another event news. So the European Symposium is happening July 5th to 7th at Belgium this time. I recognize we've shifted the venue from the boat. Now we're going to a prison. But yeah, for those of you who are attending the European Symposium, the event landing page is continuously updated as updates come. Registrations are also open right now for those of you who are interested to attend the event. Registrations will close after June 16th, so make sure you register and save a spot if you are going. Agenda is also available on this event landing page, so please go ahead. Yes, Cynthia?
Yes, so they are holding 2 days of tutorials, and registration to the tutorials is limited to 150 people, whereas they're allowing 350 people to attend the conference. So if you want to attend these tutorials, which are free, included with the registration fee, then earlier you do it, the better chance you'll have to get a spot.
Great tip, Cynthia. So there's limited seats for both, but there's even more limited seats for the tutorials that come as a freebie as part of the registration. So please, guys, if you are new to Odyssey or you want to refresh your learnings as a veteran member of the community, do register now. Yes, Cynthia?
Sorry, I also, unfortunately, because of the developments in the US, it may be difficult for some people in Asian countries like China to get visas. So this might be a better option for you if you think your country might go on a blacklist with the Trump administration.
Right, right. Lots of political situations that might impact our travels. That's also a great tip. So I think it's more impacting the Global Symposium. So if you want to meet other collaborators, maybe the European Symposium will be the better option for those of you who are impacted. Excellent. Thanks, Cynthia. I I forget that we're living in a real world where we actually have political situations and wars going on simultaneously, right? So thanks for that reminder. Right, that's on the European Symposium. Next, which also flows into our actual presentation today, right? So for those of you who don't know, there's a global initiative going on right now around doing evidence generation that are guideline driven. So at the beginning of the year, lots of study leads presented various areas that they think deserve evidence because there's gaps in evidence or there's controversial aspects in what is currently published out there. And right now, although the initiative has progressed significantly, it is an initiative that will continue on until June or July, if I remember correctly. So there is still chance for you to participate now. So please, if you are interested in contributing after you hear today's presentation, either to our presenters initiative or anybody else's initiative that is currently going on, the sign up form is still open for you to sign up using the link or the QR code here. So without further ado, instead of song speaking on and on and on, I would like to hand over the floor over to our presenter today, Chang, who is from Korea and working with Professor Chan in his lab. So Chang, you'll be sharing from your end, or do you want me to continue sharing from my end?
I'll be sharing from my end.
Excellent.
Thank
I'll
you.
stop sharing and over to you.
Okay. Can you all see the presentation?
Yes.
Okay. Okay, thank you for introducing. And my name is Chang Hoon, and I'm honored to talk to all of you today and represent the Guideline-driven Evidence Initiative that's going on in the OHDSI global scene. So let me start my presentation, okay? So I'm going to briefly introduce myself first. I'm a pediatrician and a data scientist in training. I'm part of Dr. Chang's lab in Yonsei University in South Korea. I'm interested in common data model and network studies. And as a pediatrician, I am interested in pediatric pulmonology, allergy, and intensive care. And more importantly for today, I am one of the study leads in GD 2025. So today's presentation's goals are these 2 points. I'm going to first share the context and current progress of GD 2025. And I'm also here to promote the study I am leading, antiplatelet use in acute coronary syndrome undergoing percutaneous coronary intervention, and comparing these two drugs, ticagrelor and prasugrel. So, well, I'm going to cover a lot of basic stuff, and many of you might already know what I'm going to talk about, but I target my presentation to someone a bit newer to the community, as I am also relatively new to the community, and how I learned these things. So let me start. These are the table of contents. Easy and simple. Why guideline-driven evidence? Why ticagrelor versus prasugrel? And current progress. So let me first start with why guideline-driven evidence. I'm going to talk about what clinical guidelines are and what evidence gaps there are in guidelines and our opportunity to contribute. So what are clinical guidelines? This is a piece of nice text from 2025 ACC American Guidelines of Acute Coronary Syndrome. It states, translated scientific evidence into clinical practice guidelines with recommendations. So we can see that what clinical guidelines are is translation of evidence into recommendations. And this has to be achieved based on systemic methods to evaluate and classify evidence. So how we evaluate and classify evidence is a major issue when making clinical guidelines. So how are clinical guidelines structured? Well, these tables are from ACCHA guideline, American guidelines, mainly from cardiovascular diseases, but most of the guidelines from many areas follow similar structures. So they have class or strength of recommendations and level of evidence, and they are presented together separately. Well, we have to focus on the level of evidence, and the evidences are ranked and they are given level A or more level B. Well, a lot of ranks are given based on the hierarchy of evidence we all know. And high strengths are given to, of course, meta-analysis of high-quality RCTs, and lowest evidence is given to limited data or expert opinions. So what evidence gaps can be found in the guidelines? I'm going to talk about 3 major points we consider evidence gaps that can be found in guidelines. First, there are recommendations with multiple options. For example, these are just pieces of small examples from various guidelines. This one is European guideline on hypertension. It says that among the BP-lowering drugs, these 4 classes of drugs are all recommended. So we can see that this is a strong class of recommendation with a strong level of evidence, but there are many options in this one small piece of recommendation. We don't know which one is better, if anyone is better than another. And many of you might know that these sort of recommendations are what led to the global initiative Legend Hypertension studies. And this one is what I was interested in, and this one is also from American Guidelines on Acute Coronary Syndrome. It states that both ticagrelor and prasugrel are recommended in this specific case of acute coronary syndrome. So if there are multiple options recommended in single recommendations, we as someone is learning these things, we can't know which one is better or if there are any comparison between another. So this one was the first evidence gap we found. Second, clinical guidelines often states specific points where there is insufficient or inconsistent evidence. This one is another piece of example from cancer guidelines, and it says that the optimal duration of anti-PD-1 therapy remains unknown. So because clinical guidelines are a compilation of well-established evidence that was collected during the publication of guidelines, they clearly state where the evidence is lacking and where contribution can be made. Third, there are discordance between guidelines. Well, this one is another famous example. American guidelines and European guidelines often recommend different things on cardiovascular diseases. You can see that the diagnostic criteria for hypertension or their management plans are all different based on the guidelines and what entity made the guidelines. So these 3 points are the major evidence gaps. Of course, there can be more, but these are the ones we identified. And by our opportunity to provide meaningful evidence on these points is to clarify optimal treatment options when there's multiple treatment options, to strengthen evidence when there's lacking evidence, and contribute to achieve consensus where there is discordance. So these are the opportunity and why we focused on clinical guidelines. Let's move on to the next section. So why ticagrelor versus prasugrel? Why this study was chosen as one of the main studies considered in this guideline-driven evidence generation opportunity. I'm going to now talk about this topic, and I'm going to start with the background and evidence and guidelines, and then the opportunity we found. So clinical background, acute coronary syndrome, it goes without saying that this disease is a major healthcare concern globally. And the mainstay of therapy is procedural, achieved through percutaneous coronary intervention, intervening directly to the vessel that is impacted. But the medical therapy that goes along with it is also very critical. It is the dual antiplatelet therapy is the cornerstone of medical treatment in ACS undergoing PCI. And by dual antiplatelet, I mean aspirin and one P2Y12 inhibitors. I'm not going to dive deep into what P2Y12 inhibitors. Instead, let's say that there are three possible oral options for P2Y12 inhibitors currently available in the market. It's ticagrelor, prasugrel, and clopidogrel. Let's briefly compare these three drugs. So these drugs can be compared this way. As ticagrelor and prasugrel are newer drugs, they are faster and more potent than clopidogrel. And ticagrelor is the only reversible suppressor of antiplatelet activity, and it has to be taken twice daily, unlike clopidogrel and prasugrel that has to be taken only once daily. Ticagrelor has some unique side effects such as dyspnea, and I am covering these facts because we can see here that ticagrelor is likely to have the lowest compliance from patients. It has to be taken twice daily, and there are some more side effects. So comparing these drugs, we have to see their efficacy of preventing ischemic events. This is the main goal we are trying to achieve by using the acute coronary syndrome. However, as they are antiplatelet agents, they have their own bleeding risks. So the safety of minimizing bleeding risk has to be an important factor when comparing these drugs. And sometimes composite of these two facts is important when comparing these drugs. So let's look at the current evidence and guidelines. This is the history of dual antiplatelet therapy and RCTs that contributed to it. And we have to see the head-to-head RCT comparison of these drugs. And these two RCTs are the key studies that brought ticagrelor and prasugrel into market. So I'm going to cover the landmark RCTs comparing these drugs. So one that compared prasugrel to clopidogrel was ㅍ and ticagrelor versus clopidogrel was Plateau. I'm going to go in chronological order, explaining how these evidences impacted guidelines. So ㅍ was published in 2007. It was a phase 3 double-blind RCT comparing prasugrel and clopidogrel. It compared efficacy and safety as primary outcomes, and it proved that prasugrel had superior efficacy. However, there was a major issue of increased major bleeding. So that is why prasugrel is contraindicated in some select cases of higher bleeding risks. Next, in 2009, Plateau was published comparing ticagrelor and clopidogrel. It was a phase 3 double-blind trial. It also compared composite efficacy of cardiovascular death, MI, stroke, and safety of major bleeding. Of course, ticagrelor was the better choice in terms of efficacy. However, the major bleeding safety profile was comparable. So these evidences were quickly incorporated into the European guidelines that was published in 2011-2012. It clearly states that ticagrelor or prasugrel is recommended over clopidogrel unless there are some contraindications for prasugrel. However, American guidelines, which tend to be a little bit more conservative, They were published in 2013 and 2014. However, they did not recommend any drug over another and just stated three drugs alongside each other. They did introduce the results of Plato and tritone 38 in their text, but they did not incorporate them into their recommendations. So we compare the ticagrelor and clopidogrel plus grel to clopidogrel. So questions remain between ticagrelor and prasugrel, but we have to understand that as these two drugs are already approved and in the market, comparing these drugs with RCT needs to be a researcher-driven phase 4 trial. Here, this small study, Prague-18, was the first attempt at head-to-head comparison of these two drugs. And we can see that this size of the circles is the number of subjects in the trial. So we can see that Prague-18 was relatively very small compared to Triton, Timi 38, or Plato. And unfortunately, it was a phase 4 open label and underpowered study, prematurely terminated for futility, even though it reported composite outcome comparable results comparing ticagrelor and prasugrel. Its results were largely deemed unreliable. That is why in 2017, when European guidelines updated their recommendations on antiplatelet therapy, they did not incorporate the results from Prague-18 into their text, and well, the results of Prague-18 was not even mentioned in the text. However, next 2019, RCT called ISARECT-5 was published. It was also a phase 4 open label trial, but it was sufficiently powered trial. When comparing ticagrelor and prasugrel, and in terms of efficacy, prasugrel showed higher efficacy while maintaining comparable safety. This was contrary to the previous beliefs that ticagrelor was generally better choice because of the major bleeding risk of prasugrel. And the results of ISARECT-5 raised great controversy. And it was criticized for its open label design and many tidbits of its methodology. That is why the results of ISARECT-5 was not incorporated into the American guidelines that came after in 2021. It does now recommend ticagrelor or prasugrel over clopidogrel, but it does not give recommendations or comparing ticagrelor or prasugrel. And the results of ISARECT-5 is not even mentioned in the text. However, European guidelines published in 2023 again quickly incorporated the evidence of ISARECT-5 into the recommendations. Well, the level of class of recommendation is relatively lower than other recommendations, but they do give recommendation on preferring prasugrel over ticagrelor. And this is the most recent update, latest update of American guideline. It was published in 2025 February. It still does not recommend ticagrelor or prasugrel over another, but they do introduce the results of ISARECT-5, and they clearly state that there is limited data on this comparison while introducing ISARECT-5. So we can see what is our opportunity to contribute. So there is this shifting treatment landscape on dual antiplatelet therapy. The comparison between ticagrelor and prasugrel remains inconclusive because the discordance of two guidelines remain. And just recently, the results of Plato is also being called into questions, and by extension, the merit of ticagrelor. This was published last year. The results of Plato is being called into questions, and the BMJ openly casted doubts about the results of Plato study. There are many points that the BMJ pointed out. But the most critical point was this. If you look into the details of the results from plateau study, while it showed superior outcomes in many other countries, it failed to show superior outcome only in US, where sites were not monitored by the sponsor itself. So there are some doubts about the results of plateau study. And we have already tackled this problem with CDM and network studies written by Professor Chang, and it was published in JAMA 2020. When comparing net clinical outcome of ticagrelor and clopidogrel, the results were comparable. So that is why we thought this was an opportunity to generate meaningful evidence comparing these two drugs using real-world data and CDM network study. So this was section 2. Now let's move on to section 3, where I'm going to talk about the current progress and roadmap of GD 2025 and my personal experience participating in it. So this is a roadmap of GD 2025. So steps toward evidence generation, I titled it this way. Each month was given a specific task to finish. And by June, the initial study was going to be finished, and we were considering spreading the word. I mean, publishing and making presentations and symposiums in the second half of 2025. I'm going to address this step by step. So dry January was where we reviewed guidelines and determined evidence needs. And in Phenotype February, we specified cohorts that we needed and developed and evaluated our cohorts. From these cohorts, we made study packages and study protocols, and we utilized the evidence network to find the data partners that can run the study package we need. Next is analysis April, where we finalize our protocols and specify and initiate analysis. And the analysis results from analysis April will come together in meta-analysis May, where collaborative interpretation across network will be done. And journey to June is mid-year reflection section. Let's address this a little bit deeper. We're here. So dry January was where we reviewed guidelines and brainstormed what research topics we should tackle as community. A lot of discussion was done in OHDSI forum posts and community calls. The 5-minute pitches of each study topics can be found in video presentation. This is all in OHDSI homepage. And in the forums, you can see how the discussion progressed. There's a lot of stuff going on in forums here. So if you're interested, visit this site and see what discussion went on and how all of these studies came to be. There were 14 studies that was chosen as main project targets. You can see that there's anesthesia, there's my study, bladder cancer, pneumonia, retinopathy, a lot of different study topics covering various areas from medicine is all in this 14 selected topics. They can all be found in the Guideline Opportunities tab in OHDSI homepage. So if you're interested, go there. Next was Phenotype February. We developed phenotypes for cohorts needed for the 2025 studies. So this was the overall flow, how Phenotype February went on. I'm going to address this again step by step. We first specified cohorts we needed in the studies. So there are phenotypes, a lot of phenotypes needed to define the diseases or drugs we needed in the studies. The indication phenotypes or exposure phenotypes or outcome phenotypes were all needed to be made. We first looked into the phenotype library. the database we have on all of the phenotypes we have already made in the OHDSI community, and search for what phenotypes can be reused from these previously developed phenotypes. And we specified what new phenotypes that needed to be made and what phenotypes needed to be altered from the existing phenotypes, and what phenotypes can be just brought from the existing phenotypes. Next, we built the clinical description for each of the phenotypes. This was for sharing the clinical context to the collaborators. The phenotype library, this link, also give us some useful prompts for generating the clinical description of condition phenotypes. So if you're interested, you can go here and find this useful tool. And then, based on the clinical descriptions and our study needs, we built the cohorts using Atlas tool. Many of you are already familiar with this tool. And we built our concept sets, specifying the phenotypes, and we built cohorts based on the concept sets using the Atlas. And lastly, we run the cohort diagnostics on the cohorts we built and evaluated them so if there needed to be any revision needed to make to the cohorts. So cohort diagnostic tool can be found here, and we can see you can see how cohort diagnostics tool can be used, and there's manual to it here. And this was part of the global community call February. I think it was week 4. It says that core diagnostics were executed for 9 T1 core definitions on 5 databases. So just this 1 month, a lot of phenotypes were generated from different collaborators, and a lot core diagnostics was run and evaluated the cohorts. If there are people interested in and new to the core diagnostics tool, I highly recommend you to go to the link. This YouTube link is the link to this exact exact community call, where Anna briefly gives tutorial on how you approach this core diagnostics tool and how you review the results from core diagnostics. And this link is a link to the example of the results of phenotype February. So you can see these 2 links. Go to these 2 links to see how core diagnostics tool work. Next was March to Fitness. This month what we did was matching suitable databases within evidence network for GD2025 studies. So using evidence network, study leads were matched to suitable data partners using data diagnostics process. So in the evidence network, there's many data partners providing their metadata of their databases. And these metadata were matched to the need of the study leads. So study leads filled in their what part of the data they needed. And especially here, Claire matched all of the study need of the study leads to these metadata and found which databases were suitable for running the analysis the study leads were needing. You can this tutorial on data diagnostics process was presented in this link. This one is the community call in March. I think this was the second one. So if you're interested, go visit this link too. So this was the overall progress of GD 2025 and how we progress things. Now I'm going to explain my personal experience in participating in all of this. So in dry January, this is the slide I presented you. I identified where the evidence was needed in comparing ticagrelor and prasugrel. And in phenotype February, I made all of the clinical description that was needed in my study. So you can see here that I need phenotypes for the acute coronary syndrome, for antiplatelet therapy, for bleeding outcomes, sudden cardiac death, percutaneous coronary intervention. Many of the stuff needed to be defined. Thankfully, since this was a cardiovascular area of study, so there were some really well-established studies in this community, including Legend study. So many of the phenotypes could be brought from the Legend, well, the phenotypes already made in the Legend studies. So, but some had to be altered and some had to be newly made. So I used the Atlas tool to build all of the cohorts and concept sets. And these were run on core diagnostics tool. Embarrassingly, I submitted the course that is to be run core diagnostics and a little bit late, so I was able to run on 2 databases and compare the results. So the function of core diagnostics tool is to look at various data that is generated from the cohorts on databases and see if these results matches the previous beliefs or previous data on the phenotypes we already know. For example, this is one part of core diagnostics tool. It gives us incidence of the phenotype by stratified by age and year. And we can now then compare the results generated from this core diagnostics tools to the previous knowledge we already have, and if it matches with our previous beliefs, and if there are severe discordance with our current knowledge about the phenotype, there can be something wrong about how we define the cohorts, and we have to then revise how the cohorts are defined. So various data, these are just some aspects of core diagnosis, and there are many more information we can learn from the core diagnostics. And I think it is a very useful tool for making robust evidence. Next was March to Fitness. All of analysis we needed were matched to the databases in the evidence networks. So if you see, this is an example result from my study. So you can see that the number here are all the mismatches. So if this database doesn't have one part of information, data that I need in my analysis, it is counted as 1 or 2. So these databases, if I look deeper, doesn't have data on mortality. So rest of the analysis can be done also in this database, but if I want to look at the mortality outcomes, I would have to exclude these database from running my study. So by running all of the analysis I need on the databases, a whole list of data partners that is able to run my study were selected and given to me by Claire. So I'm currently contacting all of the data partners through email. So this is a long journey that is going to start. So this concludes what I was going to present to you, all of you. These are the take-home messages. So evidence gaps in guidelines are golden opportunities for OHDSI to generate impactful evidence. And conflicting guidelines on ticagrelor and prasugrel highlight the need for guideline-driven evidence studies. And OHDSI supports network studies with powerful tools and structured workflows. So these 3 points were what I wanted to present to you today. So thank you for listening. This is my contact. And if you're interested, especially in ticagrelor versus prasugrel, please contact me. Yeah, I'm needing more data partners. So thank you for listening.
Thank you, Changwon. Subin, you raised your hand by mistake, right? Okay, I see you clapping now. Okay. That was a great session. To be honest with you, Changwon, I saw you had like 60 slides, and I was thinking, would he be able to go through this in the time he had? But yeah, I think you prepared really well. You even left time for us to have some Q&A, so this is excellent. I
Thank you.
think what you presented provides a good overview of what has been done up until now, specifically for your study, but I'm pretty sure it's exactly the same method for other studies, right? Except it's the
Yes.
details will be different and more specific to each of the other studies. So this is a good learning experience for the rest of the community. I also recognize moving forward, we need to do meta-analysis, and we also need to disseminate the results either within the OHDSI symposiums or further out to the general community through publications in peer-reviewed journals and etc. So that was great. I think why this is also very informative for us, and I'll also open up the floor instead of me talking continuously, but I think why this is relevant to us as the APAC community is for the China studies that currently have been selected, right? We have been having discussions around potentially mirroring the approach that the GDE initiative is currently taking. So essentially, we would be a few minutes behind in following how you guys are doing this. Of course, we recognize that some of these steps here won't be applicable to us, right? Because, for example, the dry January part, we've already selected the studies, right? So we could potentially skip that. But I do think we need to put in the time to see if there's any existing phenotypes that we can use, if there's any new phenotypes we need to develop for the selected studies, and also what data partners can we find in the community, and all the fun stuff that you're currently doing. So this is, I think, a good outline of what we need to do if we are to mirror this specific approach. So thanks for that again. Any questions for Changwon here from the community? Before anybody raised their hand, I did put in the chat, the OHDSI Evidence Network is quite powerful, right? So you guys just saw how the OHDSI Coordinating Center played a role in matching a study lead with a potential data partner, right? And I think the key point here is no data is given, it just provides insight on what sort of analysis is suitable to the specific study for the specific database. And all the conversations after that happen between the study lead and the data owners themselves, right? So if you want to open up your database for potential OHDSI network studies, the first step you need to be taking is actually onboarding your data to the OHDSI Evidence Network. So I put in the sign up form in the chat for those of you who are interested and in potentially listing your database in the OHDSI Evidence Network. Yes, hands, Cynthia.
Oh, thank you so much. That was a really excellent talk. One of the things I've always been impressed by is the figure where it shows the like propensity score, the distribution of like patients before and after propensity score matching. Is that being done for this study? And can you explain, what package does that? And do you have any results?
The propensity score matching is part of the basic comparison study package that it can be generated from Atlas. So it's part of that. So if you make the cohort and if you make the analysis in the Atlas tool and download the package from it, the propensity score calculation and propensity score matching or stratification is all inside that package. So you can specify specific points if you want to to stratification or matching, but all of the tools are already provided in the core. Yeah, as Subin Kim just said, core method package. So it's part of that. So yes, all of those will be done in all of these studies too. Well, we haven't run the studies yet, so we're just calling the data partners now, so I don't have the results to show you, but that is our plan, yes.
Thank you.
So to summarize, if you create a patient level estimation, a population level estimation analysis in Atlas, our package will be created, and inside the R package, part of it is the court method package, which does the propensity score matching, and all the lovely infographics, not infographics, the figures you see for OHDSI studies, right? So it's available in Atlas to create that package. You can specify various configurations or parameters in which you want to do this as well. So for those of you who aren't very familiar with the estimation function in Atlas, now is your time to go and watch the tutorials. Yeah, it's quite difficult if you watch it for the first time because interpreting the results and stuff like that is quite difficult. And I would say statistically, you need to have some sort of statistical knowledge in order to interpret those results. Thanks for the question, Cynthia. Thanks for the answer, Changwon. Jiwon, you have your hand up.
Oh yeah. I think I really trying to prepare today's presentation like from beginner's perspective because the storyline was like that he wanted to bring out to the community was very clear and well structured. So I want to thank to Changwon again. And anyway, I have one question. In like the slide that you're sharing right now, I can see like 6 steps phases. And which phrase is the most challenging in your opinion, and why is that? I want to know that. Can you share that?
Challenging.
Most challenging phrase.
I think I think what I am doing right now, contacting the data partners, is most challenging. I distributed the emails to all of the data partners in that list, and I got one answer, but I don't know if there will be more answers, but I'm waiting for more. But and I am hopeful, but I think proceeding all of these with data partners, well, collaboration, well, it's easier said than done, but yeah.
Yeah.
Oh,
I got one more question, but
yeah.
I think Stephanie can ask a question. Yeah. And then if we have a time, I can ask him personally
You
or
can just
during the
ask me here.
maybe I will give a chance to Stephanie. I
Septi,
think that'll
go
be
ahead.
better. Yeah, Stephanie. Yeah.
Hi, Chang-hoon. Sorry, I haven't looked deeper into the protocol, but I just wonder, like, do you like exclude or classify a patient with high bleeding risk or low bleeding risk, or you plan to do like a subgroup analysis for the high patient with the high bleeding risk or low bleeding risk? Because maybe it have a concern with the safety issue for the bleeding risk.
I think that's a really good point, good question, and great point. What we are doing, well, in the protocol, it says that we are going to exclude the patients with previous bleeding events. The reason for that is that Prosgro is already contraindicated in those patients. So to compare the tick where we have to think of the real world scenario when we are going to compare ticagrelor and Prosgro as possible options. If there is already high bleeding risk, we are not going to consider giving them Prosgro. We will give them ticagrelor. So, well, I don't think so. Separate analysis on high bleeding risk patients I don't think it will be possible. And currently, there's not in the protocol, I don't think we'll be stratifying the patients into high bleeding risk and low bleeding risk in there. because I don't think that won't have any merit. But we will look at all of the covariates and see if there are any things that we can consider. So thank you for the question. Yeah.
Thank you. Jiwon, you can ask your question now. There's 3 more minutes.
3 minutes.
Okay. um, like, for those who are interested in network studies, but do not have any backgrounds in medicine or pharmacy, like how can they get involved in the network study? Like, because since you're the study list, I want to ask that. Like, frankly saying, like.
Oh, I don't know. Attend community calls and go into OHDSI. Well, if you have interest, I think just if you're going to start taking interest in this, I think following the community calls is really good because it sees the flow. You can see the flow, how discussion progressed, and they give tutorials, brief tutorials on stuff. So I think that is very informative and helpful. Well, that is all I can say.
Thank you.
Cynthia?
Yeah, thanks. I was so impressed when the clopidogrel study came out. That showed that even though the superiority was established in a randomized control trial, in the real world, the outcomes were really right on top of one another. What's been done to get this result into existing guidelines and, have a change in clinical practice? Over.
What has been done?
I think Changwon already described that, right? I think a lot of the study results have been incorporated into the guidelines, either directly or indirectly, right?
I missed that. It has been changed because I thought it was still kind of like it's still an option to use either one.
It's incorporated into the recommendation in European guidelines, but it was not in your American guidelines. So that is the discordance of guidelines that I tried to address. So I think American guidelines are much more conservative when they are incorporating evidence into their recommendations. So you can see that that was very late incorporating other stuff into their recommendations. So well, each institution and each group has their own standards. So
okay. Well, like since clopidogrel is less expensive, I think there's also a big savings to national health insurance nations with national health insurance to try and control costs. So
that is why they are all attacking ticagrelor right now too.
Okay.
Right. We're right on time. Any last questions before we close the call? Maybe I'll do a closing comment, right? So, Changwon, I think maybe in terms of the terminologies you've used here, right? I think you did great in distinguishing efficacy and effectiveness. I think this is very good practice, right? We can't be using the word efficacy in real world studies because we're not looking for efficacy in a controlled environment, right? We're looking at a real world setting. So I think that not everybody distinguishes that well and uses correct terminologies. I think what you did was a very good practice, and thank you for that as well. So before I keep blabbering and I keep you guys for longer, I'll shut up now. Thank you all for being here today. Changwon, thanks again for the great presentation. It will be a great reference for us as we plan out the APAC studies with the OHDSI China collaborators. Thank you, everybody. Take care.
Thank you.
Bye-bye.
Good one.
Thank you.
Thank you.
Thank you. Bye bye.